we are going to continue our interesting session. This is about airway compression and stenosis. This time we are going to the surgical part, the management strategies on the surgical point of view. I'm glad to introduce our third speaker today, Dr. Mohammed Aklabi. Dr. Mohammed Aklabi is the Chief of Congenital Cardiac Surgery at the University of Alberta Hospital and Stollery Children's Hospital. He had been staff pediatric and congenital adult congenital cardiac surgeon since 2012 in Alberta University in Canada. He's having a major role in pediatric and adult congenital cardiac surgeries. He's also contributing very much in the academic sessions and surgical intervention and follow-up. He's a assistant professor there in the University of Alberta. He's having also very interest, and he's an expert leading surgeon for pediatric tracheal reconstruction and slide tracheoblasty. This is his field of expertise, and we are going to continue our session about the surgical management, surgical point of view of the airway compression. Dr. Mohammed Aklabi, the mic is yours.
Can you stop sharing so I could share mine, please?
Yep.
Assalamu alaikum wa rahmatullahi wa barakatuh. Alhamdulillah wa salatu wa salam ala rasulillah. First, I would like to thank the organizing committee for the invitation to join this group. Let me go from the start. And I would like to first speaker, Dr. Reem and Dr. Mohammed, on making it easy for me and nice outline. Can you guys hear me?
We can hear you, yes.
Okay. I'm gonna actually speak about the surgical part of the compression of the airway and stenosis and some of the management. What we do here at the Alberta Heart Institute and the Stollery Children's Hospital, we are probably the biggest referral center in Western Canada. We cover from Manitoba to all the way to the British Columbia. So we have a big catchment area, and what we perform around 800 pediatric cases a year, plus around 200 adult congenital. And this is Edmonton in the winter time. But it's not always snow. We have a nice summer sometimes. This is the mountains. It's actually a couple of hours from Edmonton. But I'm originally from Bisha, Saudi Arabia. That's what I grew up. And I think being from that part shaped me and shaped my career. Always proud to be from there. I have nothing to disclose for this topic. I'm going to start with one case, just to outline the talk. That this is a baby, was actually around 2.5 kilogram, was born in Winnipeg, which is 3 hours flight from Edmonton. The baby had difficulty breathing at birth, but they tried to intubate. It was difficult for them, and barely they passed the tube through the vocal cords. They called us here because we support them from a surgical point of view. They found that he has severe congenital long tracheal stenosis with LPA sling. What we did, we have sent my team to cannulate the baby on ECMO because his tube was not stable. So we brought the baby here, and immediately I took him to the OR, and we did a slide tracheal reconstruction and fixed the LPA, and he went back home. We took him off ECMO, the first same procedure, and he went back home after 10 days. We published this case in 2017 in the Annals of Surgery. So what we did when I started here in 2011, probably in 2011 is 2012, there was some cases being done regarding tracheal reconstruction, but was no dedicated team. So, and these cases are difficult to have an interest in, so I developed an interest in these cases. So we developed a program. We have a dedicated team. So me and one of my colleagues from A&T, Dr. Hamdi Al Hakim, and from our colleagues in ICU, PICU, and also in NICU and anesthesia. So, and the main thing about these cases, because they are really rare cases, you need some people that they have done it multiple times to have a success. And I think, as I said, the key success to have this program is to have a dedicated team. So every time it's one surgeon that does it from each part. It's one team. So we developed the experience of over 10 years, and actually it's rare, but we have developed and performed over 40 cases over the years with a great experience, and that's ranging from trachea, bronchial reconstructions, and on all kinds of problems. And now we actually became the largest referral center in Canada. So I will say surgical reconstruction is the primary method for severe obstruction. And as I mentioned, Dr. Reem and Dr. Mohammed actually gave a nice discussion and overview of the stenosis and the obstruction. And I would say tracheomalacia is one of the difficult to fix, even by surgery. I have done only one case with baby. They could not extubate in NICU, and I have done a posterior plexi for that baby. So the problem with tracheal stenosis is frequently associated with a congenital heart defects, so which usually may further complicate the problem. So most of the time, around 20% is isolated trachea problem, but what we have seen more than 80%, they have actually a heart problem. So what we do, we always fix also the heart lesions at the same time. So as mentioned before, the trachea usually has 15 to 20 shaped rings. And posteriorly is interesting, the trachea has that membranous muscular tissue, which is very important. Because what we found, the patient who has complete stenosis or long segment or short segment stenosis, they have complete rings, and this actually muscular tissue is not there. So as mentioned before, this is the tracheal shape. It's always half ring, almost 2/3 rings, and posterior wall is a fibromuscular posterior wall, and that's very important. But there is always anatomical variations in the trachea. We have done surgeries in patients with a big bronchus, and then I used that big bronchus to enlarge the right main stem in one patient. So the types of obstruction we have seen, either congenital stenosis with the complete rings, and either long or short, and could involve the trachea, even both bronchi or one of the bronchi. And the other problem is compression, either by aorta or nominate artery, and we have done procedures like aortopexy in those patients through anterior thoracotomies. Or if it's actually a cardiac surgery patient, then we just do an aortopexy at the end of the procedure. Also, as mentioned before, from my colleague, that dilated pulmonary arteries as trilogy absent valve patients usually have a large PAs that actually cause severe compression on the PAs. And then we don't like to operate in those patients, to be honest, unless we are really forced, because if they need surgery at the neonatal period, that they're really sick patients and they're severe. So what the procedure I have done is to move the PAs completely anterior to the aorta by doing a LeCompte maneuver. All kinds of vascular rings with airway compressions could happen. So we really investigate if there is a problem with the patient and find out if it's vascular rings, we'll just go ahead and fix it. As mentioned by Dr. Mohammed, bronchiomalacia is a problem, and that usually by exocclusion, but also our colleague from ENT, by doing bronchoscopy, they will diagnose the bronchiomalacia from the shape and from the way that the trachea looks with extubation or intubation. The congenital tracheal stenosis, as I said, could be a short segment or long segment, and usually they have complete tracheal rings. So even if the trachea is not severely narrowed, if there is complete tracheal rings, we'll just go ahead and do the surgery. And as I said, could be isolated or associated with congenital heart defects. These are the heart defects that we have fixed, and actually we have fixed all those kind of lesions in all our patients, and mostly tetralogy lesions. The last patient actually was around 1.8 kilogram with pulmonary atresia and VSD. We had to do a full repair and also fix a trachea at the same time. And as I mentioned, the most common presentation is biphasic stridor on those babies. And usually symptoms range from mild to severe. If it's really severe, they might need urgent intubation or ventilation, and sometimes the ECMO support, as I mentioned before. So our assessment and patient referral, usually if the patient is stable, then we'll just go ahead and do an echo, bronchoscopy, CTs. Usually those CT, I'll ask for a CT with a 3D reconstruction just to help us and guide us. But also bronchoscopy is very important. If the patient is unstable, we have to fix it, stabilize the patient first, and then do the studies afterwards. Diagnosis, a prenatal diagnosis. We tried to diagnose them prenatally. Actually, there was a month ago, there was a pregnant lady in Saskatchewan had twins, and interestingly, both twins has tracheal reconstruction, tracheal stenosis, as well as LPA slings in both babies. So I applauded the team there who diagnosed both babies antenatally. So what we did, one of them was actually severe, looked in the echo prenatally. So what we actually brought the mother here, we did the surgery. She had C-section in our OR just to make sure the babies that are okay, they might need ECMO afterwards. Luckily, the baby were okay. One of them is still sick in the NICU. Actually, I might do him tomorrow. And his brother, I try to wait for a few months. Chest X-ray, echo. We have to do echo for all our patients, as I mentioned, because mostly they'll have congenital lesions. Bronchoscopy, flexible or rigid. What we do now, actually, we do bronchoscopy just immediately before we go to in the operating room, before I open the chest. Because sometimes if you do bronchoscopy in a severe stenosis, you might actually make them sicker, or so I think it's safer to do it before going for surgery on table. CT scan with airway theater construction is very important, and MRI. And this is, as I mentioned, those are the twins with LPA slings and tracheal stenosis, as I mentioned before. So the C-section was done here and in our hospital. So this is a baby actually who has isolated tracheal stenosis. Just go back for a second. So this is a bronchoscopy, and you could see there in the bronchoscopy, the trachea looks okay here, but you could see down there just before the carina, there is severe stenosis. And then when the scope passes that narrowing, you'll have it opens up at the carina at the bifurcation. I have a video of the surgery. I'll show you at the end how did we reconstruct his trachea. This case, because it's really short, and so what I did, I just did resection and end-to-end anastomosis. So this is the CT of this baby. You see where the narrowing is actually just above the carina. This is another patient, who's a different patient. So the surgical reconstruction of long segment tracheal stenosis has been achieved using a number of techniques, and either simple resection, as our baby I'm going to show you. Some people did the pericardial root cartridges or tracheal aortograft patching, slide tracheoplasty. We haven't done the pericardial patches, but now we're doing mostly slide tracheoplasty. So what we do in this case is we do it on bypass, because most of the time there is cardiac lesions, and we fix the lesion at the same time. The LPA slings repaired by reimplantation. We mobilize the trachea completely. I use bipolar diathermy because we should protect the recurrent laryngeal nerves. Sometimes we divide the thyroid, thymus, hilar, and hyoid release if needed to bring the trachea down. And we use absorbable sutures running posteriorly and interrupted anteriorly. And as I mentioned, most of the cases we do is a slide tracheoplasty. It gives you a nice reconstruction. Also, what it does, it actually increases the size of trachea and to double. So this is a view there's a cannula in the aorta, you could see it there, and another cannula in the right atrium. You could see that the trachea behind the aorta. And it's very important we preserve the recurrent laryngeal nerve, so we are really careful in dissecting in that area. So when we cut in the middle of the trachea, it's actually middle of the stenosis. And then the upper part, we opened it posterior wall. We opened all the way to the normal rings. Anteriorly, the lower part, we opened anteriorly all the way to the carina. And then we overlap them on top of each other. And you could see there, it's actually give you almost double size or twice size the diameter. It will be a little shorter, but the size will double. This is a 14-year-old patient. This is the older and the biggest patient we did. The smallest actually was 1 kilogram. The 1 kilogram, because he's so tiny and preemie, there was discussion about withdrawal care. The parent asked if we could do something. I asked them, it's going to be high risk. So what we did that off pump by just doing a sterile intubation and distally into the carina while we are actually fixing the trachea. That baby is already 2 years old. This patient also had a subaortic membrane, so I was planning to resect. But you could see here, when I opened, there was a pseudoaneurysm in the ascending aorta. So what we did, we also fixed that at the same time. So you could see here, there is a patch on the ascending aorta reaching to the root. On this side, this trachea, we had to go all the way because her stenosis actually was higher. So we opened in the neck as well. You could see the cannula in the aorta there. The nominate artery were pulled away, and that's a trachea. Here we divide the trachea, and here I'm cutting on the posterior part of the trachea and the top part. And the lower part, we usually cut anterior. You could see it here. And then we start the anastomosis posteriorly with the PDS sutures, and as I said, running posteriorly and interrupted anterior. So that's the first baby I showed you. This is post-op bronchoscopy that has localized narrowing above the carina. And you could see now, from now, you already could see the carina nicely without any obstruction. We reimplant the pulmonary artery at the same time. So after surgery, it's very important to manage them in the ICU, and our colleagues, they have an excellent experience now with these patients. So what we do, we actually try to extubate them first day after reconstruction. We try not to leave the tube for a long time. So we do bronchoscopy at bedside quickly and before extubation. We do swallowing assessment. Some of them might need some few bronchoscopies before discharge. We had a couple or 3 cases that had developed some build-up tissue in that repair, so they did some dilatation with the bronchoscopy. But tracheostomy is very rare. We had 1 case had tracheostomy, and there is another case had actually tracheostomy pre-surgery. So as I mentioned before, if you go in the literature, those cases are rare. The biggest actually in the literature was 40 cases. We actually are approaching more than 40 cases already. We have 2 cases to do this week. So this is over the last 10 years and range from neonates to teenagers. As I mentioned, the smallest was 1 kilogram baby. Survival was 100%. 1 patient has tracheostomy, and most patients has slight tracheoplasty. Couple had resection because it was really short and localized. And 20% of those patients was diagnosed with isolated tracheal stenosis. 80% of patients has associated cardiac lesions. And this is a paper by Peter Manning and his group, and they have 40 cases. And they mentioned in their conclusion that slight tracheoplasty with a bypass is an effective treatment for those patients. This is another paper from Frank Halley group in Stanford. And also they mentioned about tracheoplasty. And then their patients, some of them actually had delayed presentation. So this is that baby we have done. I showed you the bronchoscopy first, has isolated tracheal stenosis just above the carina. I'm gonna, hopefully this video will work. Okay. Sorry, I'm going to try to open it again.
One minute left, Dr. Mohammed.
Sure. So you can see we're cannulating the aorta. I'm trying to skip through this very quickly. So we put the cannula in the aorta, cannula in the right atrium, dissect behind the aorta. You could see the trachea there. I'm trying to feel for the tube because the tube was just above the stenosis. It's very important to mobilize the whole trachea to have you could bring it down. We always use bipolar to protect the recurrent laryngeal nerves. Now we are opening the trachea anteriorly. So we divide it completely. I ask anesthesia to pull the tube back. You might need to give me a couple of minutes, Dr. Abdullah, if you don't mind, but we're almost there. So this case, I resected the stenosis. So we started, I could show you that this is the carina there, and we'll do the anastomosis posteriorly. So we pull the sutures with the nerve hook. So the posterior wall is already together. And then anterior, we'll just do interrupted sutures. And that will complete the tracheal reconstruction. So what we do at the end also, I'll put some saline just to check for air leak. And then I'll ask anesthesia to pulse alpha. And you can see there is no air bubbles and it's watertight. And also what I did, I'm not sure if I showed it here, I have a flap of a pericardium between the aorta and the repair. Thank you.
Thank you, Dr. Mohammed, very much for this very interesting and very nice presentation. You will remain with us for another 10 minutes. We have question to be reviewed by Dr. Omar Hijazi. Dr. Omar, if you have any question for the panel session, you can start now. Dr. Omar, any question around you?
I don't see if you can see this. Dr. Abdullah, I have a question if you don't mind. For the group, we struggled with patients with malaria, and so in certain occasions they have to stay ventilated for a long time, sometimes 1 month or even more. We have patients that stay 2 months or even more in the ICU. What can you do for these patients who failed repeatedly trials of extubation? What can you do for them? Can you do stent? What can you do?
I think go ahead.
This question for Dr. Mohammed, yeah, okay.
Yeah, I'll mention just quickly. Stenting the airway, to be honest, we don't recommend it. If the patient needs tracheostomy, maybe you should go ahead, but we try to localize where is the malacia exactly, which part of the trachea, or if it's actually in the bronchi. And as Dr. Mohammed mentioned, sometimes we could do some PEXI for those and help them. But if it's really severe malacia, that's usually a difficult problem to fix. But we don't recommend stenting the airway. We're just asking for trouble.
Thank you. Anybody had other questions, please?
Another question, Dr. Mohammed, what is the priority of the investigation? I mean, did you start by the bronchoscope first or CT first, CT chest with reconstruction?
I think as Dr. Reem said nicely, first stabilize the patient. I think if the patient is really sick, we have to stabilize him by any means, sometimes even go into ECMO. But I think, and then if the patient is stable, we start with bronchoscopy that would diagnose CTs and the echo.
Good. Dr. Reem, you have any comment? And Dr. Papani also, if you have any comment, we have time for like 4 minutes more for discussion.
Thank you very much, Dr. Mohammed. Really, I enjoyed your lecture. I have seen, or at least we dealt the worst cases we have seen, tetralogy of Fallot, absent valve. Was that your experience, or who are the substrate of congenital cardiac lesions? We dealt with a lot of vascular ring. I did not see them as major problem, but truly the one that we struggle the most with is tough absent pulmonary valve. I would like to hear your opinion, Dr. Mohammed, as a surgeon.
Yeah, you know what, I agree with you. I mean, what we look at these patients, if the patients present at the neonatal period with severe obstruction, that's usually a problem. Because if you can wait for the baby to fix him in 5 months, 8 months, 10 months, that will be the best. But if you are forced to fix the baby at the neonatal age with a severe airway obstruction, then at that time, I will take the liberty and actually do a LeCompte. And also at the same time doing LeCompte, I will reduce the size of the PAs, because that when the patient presents at that age, that means the PAs are massive, compressing both bronchi. So what we do, we reduce both PAs size, and then I'll move them anterior to the aorta, and I use a conduit. You will struggle with them a little bit after surgery as well for a few weeks, but you could see now the PEEP. You could have actually weaned the PEEP down over time after doing this. But I agree with you. This is that difficult patients to manage.
Thank you.
When do you say that the patient has spent too much time on the ventilator? When do you say that supportive nutrition and supportive treatment is enough, and maybe I should think about tracheostomy? Because when we tried tracheostomy before, we have liberated the patient from the ventilator. Tracheostomy is not going to clear the airway. It's not going to clear the malacia, but it's going to make the care easier. So when do you say that enough is enough, I'm going to go for tracheostomy? Because in our community, people here are against it. Families and some of our colleagues are against tracheostomy.
Yeah, that's a very good question, Dr. Ahmed. I'd like to hear from Dr. Reem, and then I'll tell you what we do here with our babies.
Reem, you unmute yourself. Yeah, okay.
I think what the recent recommendation is that tracheostomy, if it's not going to mobilize the patient to another level of care, like if the patient is going to be staying in the ICU, if he is dependent on the ventilator, if the malacia is lower in the airway, even if you do a tracheostomy, it won't get him out of the ventilator. What we practice is if the tracheostomy is not going to mobilize the patient to another care, like a long-term care facility or even go home and get him out of the ventilator, we usually tend to delay the tracheostomy until the child grows up a little and his airway grow. Because in the smaller kids, the tracheostomy itself has a lot of problems. It's difficult to manage the size of the tracheostomy, the length, the leak, and so on. So this is what we actually do is, if it's not going to mobilize the patient to another level of care, we try to delay it. I don't know what.
Yeah, we do the same. I mean, in babies, we try to push the tracheostomy and make it last resort, even for months. The reason for that is not it's going to affect him down the road, but it's. I mean, if you exercise all options, and this is the last option, you could do it. But I will wait a few months before deciding. Also, us, because now we operate lots in the airway, we became familiar with that area. I remember when one baby had severe bronchomalacia in the whole left main bronchus. So discussion back and forth. I took him to the OR, and I actually did a slide for that bronchus itself. He struggled afterward but at the end they could actually extubate him. So I think sometimes there is room to push the limit on those patients. And as I mentioned, that other baby with posterior pexy. And I think, Dr. Omar, if you have a patient that you can't extubate, try actually to find at least localized where is the problem, which part of the trachea or just part of the bronchi, and then it's easier to try to manage. But I would defer the tracheostomy a little bit, few months in babies.
I think we run out of time now. It is time to end our session. It is a very interesting session. Thank you, Dr. Mohammed, Dr. Reem, and Dr. Kapani. Any comment from Dr. Omar Hijazi and Dr. Mohammed?
I agree with you. It was a great session, and we learned a lot. And inshallah, we'll look forward to hear again from you. Thank you much all.
Thank you. We're honored to be with you guys. It was a great session. Thank you guys for the invitation.
Thank you so much. Thank you.
Thanks to all my colleagues.
Thank you.